So, good evening, everyone in India, and good morning, everyone in South America. We welcome you all to Ortho TV Indo-Brazilian Argentinian webinar series. And to introduce today's topic and the speakers, I hand over to our moderator, Dr. Sergio Rovinski from Sao Paulo, Brazil.
Okay, so I'm gonna start. So hello, everybody. I'm Dr. Sergio Rovinski here from São Paulo, Brazil, from Shoulder Planet. I'm very happy that we are doing now our third Indo-Brazilian webinar, and we are gonna talk about AC joint dislocations and distal clavicle fractures. How do we fix it in a very easy and many times implant-less and hardware-less way. To do that, I have a big constellation of stalwarts here with me, and I would like to make some introductions, and then I would ask all the presenters just to say hello to everybody before we start. So as everybody know, I am from São Paulo. I live in São Paulo, Brazil. I am a dedicated, exclusive shoulder and elbow surgeon. And we have here Dr. Daniel. Well, first of all, from Argentina, we have not only one guy, but we have two. So we have Dr. Daniel Moya, which is a good friend of us. He has already been the president of Argentinian Shoulder and Elbow Society. He was last year the president of the World International Congress of Shoulder and Elbow Surgery in Buenos Aires, Argentina, and hopefully all the five of us, we were there. And he's a very active shoulder surgeon, especially in terms of academics. Not only a very good surgeon, but a very good academicist. Together from Buenos Aires, Argentina, our good friend, Dr. Diego Gomez, who is a rising star in South America, a very good shoulder and elbow guy, who's also gonna present to us a very interesting case. From India, our good friend, he needs no introductions, but still I wanna mention Dr. Ashish Babulkar, who is our good friend, one of the most relevant shoulder surgeons from India, from all Central Asia. I consider him a very good friend. I have already been with him 2 times in India in his shoulder conclave event in 2017. It was one of the most beautiful moments of my personal career. And he's gonna talk about his personal experience with AC joint dislocations and distal clavicle fractures too. And from Brazil, besides my super friend, our super friend, Dr. Ildeu Almeida. Dr. Ildeu, he was the president of Brazilian Shoulder and Elbow Society in 2019, and he was also someone who helped too much in the organization of International Congress of Shoulder and Elbow Surgery last year, together with Dr. Daniel Moya. Dr. Daniel Moya knows how helpful Dr. Ildeu was in doing such a lovely event. So in summary, we have 3 ex-presidents of national societies, the president of last year Shoulder and Elbow World Congress. So I am feeling in heaven in summary. And by the way, I would like you guys just to make a small introduction and say hello to everybody before we start. So Dr. Daniel, the microphone is yours.
Thank you very much, Sergio. It's really a pleasure to be here with good friends and having this communication with Indian colleagues. I have been there also in Pune last year, and it was a great meeting. We are looking forward for the next one, and hopefully we will have the chance to keep on being in touch and sharing knowledge. Thank you very much.
Okay, Diego, please.
Hello,
Diego.
Good morning, everybody.
Yeah.
It is a pleasure for me to share this massive webinar with such nice people from everywhere. So thank you again for the invitation.
Okay, Ashish.
Hi. Hola. Obrigado.
Thank you very much for your presence. And Dr. Ildeu, just say hello to everybody. You can say in Hindi, Portuguese, Spanish, or English, whatever you want.
Well, it's a pleasure to be here again with you and
this fantastic organization. Thank you for the invitation.
Okay, lovely. Okay, good. So the thing is, this is what we are going to do. Dr. Daniel is going to make a presentation about his technique. He's been doing for a lot of years, 20, 25 years. He's going to tell us something very interesting with PDS sutures, and I am very interested in seeing this because there is a lot of similarity with what I've been doing for about 13, 14 years here in São Paulo, Brazil, and many other places in the country. And after that, Dr. Ashish is presenting a lecture, and then we will start seeing cases. A very interesting case from Dr. Daniel together with Dr. Diego. That is a very nice case from Dr. Ashish, and I have very interesting two very interesting cases to show in a sequence on the rationale of everything that I have been doing. And meanwhile, we can do a lot of discussions and show to I would say to all of the audience this. I just want to mention something that I have been discussing with Dr. Daniel for the last 2 months. Besides all of the technical issues about this technique that we have been doing, it's a technique that it's very interesting from an economical point of view, and especially in the Brazilian scenario, in the Indian scenario, in which we have all of issues about this. But much before that is a very good technique from an orthopedic point of view. So, Dr. Daniel, can you start? We are not hearing you.
Sorry. Yes,
Okay.
I will share the screen. Thank you very much.
Okay.
Well, thank you, Sergio. I think that one of the nice particularities of this issue is that there are a lot of controversies, and I will try to focus this from the point of view of the controversies. I will not go in deep in the technical procedure because I know, Sergio, that you will analyze that, but I can give you my point of view later. The controversies begin with the anatomy. There are points that we should discuss about the anatomy and the physiopathology of the acromioclavicular separations. Most of the classifications, the decisions for surgery or for treatment are based on studies that were done doing the sequential cut of the ligaments. Cadenat in 1917 was the first one. There is another very important paper by Jurist, and we are seeing here a picture from Fukuda's paper in 1986 that is also very important. But all these studies have analyzed the sequential cut of the acromioclavicular ligaments and of the conoid and trapezoid ligaments that we call the lateral coracoclavicular ligament, but no one included the medial coracoclavicular ligament. The medial coracoclavicular ligament, or Caldani ligament, was described by Caldani, an Italian anatomist, in 1821. Here you can see on the left side dissection in a fetus in which you can see it, and on the right side the medial coracoclavicular ligament with its two portions, posterior inferior and anterior superior, that is going from the coracoid to the clavicle, and it was recognized especially by the Italians, the French, the German anatomists, but not by the Saxon anatomists. There is even a paper by Classen that recognized that it is described, but they said that they never found it when they were doing dissections. In our case, we found this as a constant structure in all our dissections. But we went ahead and designed a protocol, an MRI protocol, to try to depict it by MRI. And for the first time, it was shown that we can see the medial coracoclavicular ligament in MRIs of volunteers, including me. So it is a constant structure. But the next question was if it contributes to the stability of the acromioclavicular joint. So we perform the sequential cut of the ligaments, including the medial coracoclavicular ligament. You can see on the left side the separation between the acromion and the distal clavicle when we cut the acromioclavicular ligaments, and the average was 15 millimeters. Here you can see the conoid and trapezoid, and here the medial coracoclavicular ligament. When we cut conoid and trapezoid, the lateral coracoclavicular ligaments, the average of the separation is 42 millimeters. It goes from 15 to 42. So there is a clear and evident difference. Now, the next step was cutting the medial coracoclavicular ligament, and we saw that the average separation went to 63 millimeters, and this is significant. So we must consider that the medial coracoclavicular ligament could be responsible between the difference comparing type 3A and type 3V acromioclavicular separations. We have also seen that when you cut the medial coracoclavicular ligament, there is a bigger displacement backwards, so could be damage in type 4 injuries, and of course could be involved in type 5 injuries. Rockwood, with whom I train, described that the difference between type 3 and type 5 was the detachment of the deltoid and the trapezoid. But we think that this ligament could have a role. So as you see, there is discussion and there are controversies even related to the anatomy. We must not forget the stabilization by the muscles, and this dynamic stabilization by the trapezoid and the deltoid is very important. And when we proceed with the open repair, it is an option, a very good option, to make a suture of the aponeurosis, the fascia between the deltoid and the trapezoid. What about the classification? Well, Rockwood's classification is the most used, but it is based on the coracoclavicular space distance, and now some papers are coming saying that it is better to measure the difference between the acromion and the clavicle, as we did in our paper. For instance, this is more useful when considering type 4 acromioclavicular separations. Treatment decision-making is really controversial. If we consider evidence-based medicine, as usual, they say that there is not enough information, but there is a tendency to think that conservative treatment gives the same solution and the same result than surgery. We think that saying everything should be operated or saying everything should be treated conservative is not a good option. And we should analyze some details. For instance, this is a very interesting paper that analyzes the fate, as they say, of acromioclavicular injuries in athletic injuries. And they follow up the patients for 6 months and realize that almost 70% of type 3 acromioclavicular separations have symptoms after 6 months. So we think that we should consider that for special populations, it is important to evaluate surgery from the beginning. This is a very interesting paper by Gumina from Italy, and he discovered that those patients with chronic type 3 acromioclavicular separations have, in the 70% of cases, scapular dyskinesis, and this could alter the function of the shoulder. He also pointed out that patients with chronic acromioclavicular dislocations have a higher chance of suffering pain in the cervical spine. So there are some sequelae from an acromioclavicular dislocation that should be considered. Charles Rockwood used a clinical criteria to decide surgery. He said that in patients younger than 25 years old with high expectations related to their sports and considering the type of job, if jobs in which it is necessary to do activity with the arm over the level of the shoulder, is better to decide surgery. He used to say that in some sports like rugby, in which acromioclavicular dislocations are so frequent, it is not a good idea to operate these patients, because if they keep on playing, we have a high chance of receiving the patient back with another dislocation with time. But I heard for the first time speaking about type 3A and 3B injuries to Karl Basmenia. He said that we should consider that not all the type 3 injuries are the same. There are type 3 dislocations that are stable and type 3B, in this case, dislocations that are unstable. And this type 3B deserves surgery. How do we recognize the difference? When one of the clinical tests is the cross-body adduction. And when doing that, if we see that the clavicle steps on the acromion, it is a sign of instability and we should consider surgery. This can be also shown on x-rays, as we can see on the right side. So my position is that I prefer conservative treatment, except in young patients, especially if they are involved in throwing sports, if they use their arms over the level of the shoulder when working, and if I consider that the patient is having a type 3B injury. What about the treatment timeline? There has been some discussion about this, if waiting to chronic situation or decide surgery on acute situation. Well, Ben Kibler told me once in a personal communication that he had become more aggressive with surgery, with deciding surgery, because the results are better in the acute situation. And this is like discussing if we prefer to repair or to reconstruct. This is a patient with a chronic dislocation in which we performed Weaver and Dunn procedure. We need to alter anatomy to get some stability. So we prefer not to do this. We prefer to do a repair, to respect anatomy. Frank Golke published a paper in 2008 showing that when the surgery is early, the patients got a higher constant score. It is easier to get an anatomical reduction. There are less complications, and the patient satisfaction is higher. So we prefer to perform surgery in acute way when possible. What is acute? There is also discussion about this, but I can tell you that the consensus today is that acute is in the first 2 weeks, because it's the situation in which we will be able to find the coracoclavicular ligaments. Another point of discussion is if we should resect the distal end of the clavicle or not. I was very lucky to be able many years ago to present a paper at the AAOS meeting that we did with Basmenia and Rockwood. And we showed that there were many complications of the resection of the distal clavicle. Besides technical failures and diagnostic errors, there were complications that were unpredictable, like, for instance, the ossification in the area of the resected clavicle, and even the appearance of very painful scars in the area. So I prefer not to resect the distal end of the clavicle when doing an acute surgery. Another point of discussion is if we should repair or not the coracoclavicular ligaments. In this paper that was present at the International Congress of Shoulder and Elbow in Korea, it was said that it is worth to, in Japan, it is worth to repair the ligaments to get a better kinematics of the acromioclavicular joint. We must remember that ligaments have not just mechanical function. They are also included in reflex and in the proprioception that contributes to joint stability. So some people have said it is not possible to find the lateral coracoclavicular ligaments when performing surgery. I must remember you that some people have said that the medial coracoclavicular ligament was impossible to find, but it is there. And when you perform the surgery in an acute period, you will find them. There are different types of injuries, but look at this, how nicely can be shown in an acute case. Here I am holding the trapezoid ligament. Besides that is the conoid ligament. Here we see behind that is the conoid ligament. Here we see a case that we operated on. You can see before and after surgery. And another point of discussion is if the coracoclavicular ligament heal or not. Some people say we do not operate, we do not repair the coracoclavicular ligaments because they don't heal. And they heal. We took MRIs, control MRIs 6 months after surgery. And here you can be in the sagittal view that the ligaments appear and are there. So it is worth to perform the repair. Another point of discussion is open or arthroscopic procedure. And I think it is up to the skills of or the education that anyone has received. But it has been demonstrated that the results between comparing open and arthroscopic repair are similar, but arthroscopic procedure is more expensive and takes more time. So it's up to you. If you have a lot of money and time, you can do it arthroscopically. If not, you can do it open. I use it, the open procedure. I do not see benefits from performing an arthroscopic repair, at least so far. Perhaps in the future, they will demonstrate that this is a better option, or there are improvements in the technical procedure. We should also discuss what methods of containment should we use. And I think this is one of the biggest discussions related to this topic. The use of non-absorbable sutures is not a good idea, because with time you could see these kind of complications. The sutures will cut the bone in some cases. We have quit from using Kegner wires, and I have not seen good results with the Bosworth screw, even though Dr. Rockwood was using it for a while in the 90s. And the patients, even in the best cases, needed a second surgery between 6 to 8 weeks after the procedure to take the screw out. What about this plate? I would never use it in an acute case. I think that this plate has an indication in very specific cases for reconstruction. But to use this for an acute case, it seems to me is not a good idea. There are many complications that were described related to infection and to osteolysis of the acromion. And it is not worth to go back and have a second surgery to take this out. But in specific cases of reconstruction, I think could be a good option. For instance, if you are using a graft, a bone graft in a case in which there is a lot of bone that has been that has disappeared for previous surgery. What about the tight ropes? Well, I have also seen complications. For us, they are also expensive. And there's many papers speaking about 50% of bad results, considering that it's not an adequate procedure. And you see that even with time passing on, the results are really controversial. There has been said, for instance, that some procedures that, like the graft rope, has near 100% failure. And I cannot give my patients a procedure that is close to 100% failure. I prefer to be more conservative and use a procedure that has shown to me that gives good results. This is a multi-center study that was published a few years ago, and they evaluated 116 cases in 1 year, and they found a 41% of persistent dislocation and 22% of complications using arthroscopic procedure after acute acromioclavicular dislocation. We would not accept these results. And this is another paper where you can see that there was loss of reduction in 33% of the patients and a total of 44% of complications. So results are far from being excellent. As we said, I use the cerclage with PDS, is a resorbable suture that gives us a very good option and very good results. But there are also controversies here. This is a paper that says that not sufficient vertical stability was achieved using cerclage. But I can show you a paper saying the opposite. And this is a paper by Lederman that compared 3 techniques: cerclage, tightrope, and clavicular plate, and they found that cerclage is the most physiological stabilization. So one thing are the results in a cadaveric model, and another thing are the clinical results with our patients. This was my first case back in 1994, and you can see here we used to measure the coracoclavicular distance. That's why we use this type of view. And you see the difference between both sides, and this is after surgery. This surgery, I learned this surgery from Karl Basmenia, and we use not only the cerclage, but we also explore the acromioclavicular joint, and Sergio will speak more about this. This is the result in this patient. You can see here before and after, and this is the clinical result. Another case before and after, and the clinical result. You see that the final results look very anatomic when you perform the surgery acutely. Another case before and after, and you can see here how the anatomy of the patient, the topographic anatomy of the patient changes. This is my youngest patient, a 14 years old boy that had, in fact, epiphysiolysis of the distal end of the clavicle, and the clavicle was through the trapezius when we operate this patient. And you can see here, this is the distal epiphysis of the clavicle. Here you have the clavicle that is up, and this is after the PDS cerclage done, and you can see the reduction of the epiphysiolysis. This is the radiological results, and you can see here the comparison of the MRI, the sagittal view before and after. Here you can see the disruption of the coracoclavicular, the lateral coracoclavicular ligaments, and here you can see the integrity after 6 months. This is the clinical result, and this patient was operated on around 7 years ago, and I still keep in touch with him, and the result is good. This is the patient with a higher demand that I have operated. You can see the X-ray with the overlapping of the clavicle with the acromion, and this patient was Olympic wrestler, and so he had a very high expectancy. Unfortunately, after 4 months of the surgery, he was practicing his sport again and got a prize because of it. So even for patients with high demand and a high level of sport, they can have good results with no need of expensive surgery. What about fractures? Just 2 words. We have used this system for fractures. Here you see a type 2 distal clavicle fracture before and after. And it is not necessary to resect the end of the clavicle, even if it is very little. With the cerclage, you can have good results. This is another case before and after surgery, and the results are very good with a not expensive procedure. So, in some cases, the acromioclavicular joint has been underestimated, but I want to remind you the words by Codman, considering that the acromioclavicular joint and the clavicle is a structure that represents part of our evolution, and it is worth to give this joint the best result possible. Thank you very much.
Well, Daniel, are you listening to me now?
Yes, perfect.
Yeah, so see, very, very nice. Before Ashish speaks, I would just like to make some comments. I made some notes that we could talk about until midnight, even in Brazil. But the thing is, I just would like to mention some things before Ashish speaks, and we can discuss them after. As a moderator, I think it's important for me to do that, even because I would like to highlight something very important. There are many juniors seeing us. We discuss this as specialists in a very high level, but I always try to keep basic concepts to the juniors, because in India, there are many juniors and beginners seeing us, and I think it's important to send them basic messages. So just some points, and after Ashish's, we can discuss this, but I think I noted important issues. See, the first one is we have to understand not only the displacement, but the personality of the lesion, as Jesse Jupiter says. So this is important in all orthopedics, but here is super important, especially when we are talking about type 3s, okay, A or B. Mm-hmm. About the chronic cases, I think there is a very important message in your lecture. They are much more difficult, and I am very happy that I'm going to show a very good result in a case that the lady stayed 1 year with a type 5, and all of the difficulties, the clinical, intra-op, and radiological problems that happen. This is going to be something nice. I was a little bit scared, frightened. I am a very humble guy about this medial ligament, which after 20 years of graduation, I still haven't heard about it. This is something completely new to me, very interesting. The only thing is that I think it's maybe we have been neglecting this for so many years, but I don't know biomechanically how does it make a difference. I would like you to comment that after Ashish's presentation, and just 2 more comments, and then Ashish will start. But you can always you can speak, of course. About, you mentioned something very important in the Manford procedure in the distal clavicle resection. Sometimes you have post-operative synostosis. I have 2 cases they are painful. I am a super big fan of distal clavicle resections. Okay. And I have a rationale for that, but I'm going to share to you a tip that I learned with much older guys here in Brazil, which is when I finish my surgery, I come with electrocautery very high, and I burn all of that bone in order to kill all of the osteocytes, to kill biology over there, in order to impede bone development and bone growth, in order to evolve to a synostosis. Because when we are doing, this is for the juniors, when we are doing AC joint dislocation, we are not dealing with the periosteum of the medial side of the acromion. So the synostosis is coming from biological bony activity from the clavicle to the acromion, and not the opposite. In this sense, I burn, I use the electrocautery very high, and I burn it in order to kill all of the biological activity over there. I think that this is something that makes sense in my mind. And just one more comment about arthroscopy, and then I want to hear you guys before we start the shishas. I was discussing with Indian guys 2 weeks ago about arthroscopic Latarjet, and I think that the rationale is the same. To do an arthroscopic Latarjet or an arthroscopic AC joint, you must have 3 things. You must have the patients, you must have a scope in your hospital, and you must have the time to do the learning curve, which is very, very difficult. So if you see Ashish does beautiful arthro Latarjet, I've seen when I was there in Pune, I was impressed, but I don't think, I don't feel shameful, when I say I don't do it. And I do so difficult cuff tears arthroscopically, but I don't do it. So not only Ashish is a wonderful surgeon, but he had the 3 things. He had the patience, the scope, and the time to do the learning curve. And in practice, I think that for the vast majority of the patients, this is not the reality. So this is why I think that knowing how to do an open AC joint dislocation is the key, surgically speaking, in the same way that knowing how to do an open Latarjet is the main target, much before doing an arthroscopic Latarjet. So I just, because many juniors, they keep on mind, I want to do it arthroscopically, and they don't have to rush. As long as they do it open with good standard results, and they understand the pathophysiology, the physiopathology, and the basic principles of reconstruction, I think that this is much more important than doing open or arthroscopic. And first, you shall learn how to do it open. This is a message for the juniors. If you want to comment on that, any of you will do Ashish. I would just like to hear Ashish because he has so many experience in arthro Latarjet, but this message of before thinking about this, knowing the concepts and knowing the principles, and I'm talking about, we are not talking about Latarjet, but AC joint, but the principles, the rationale are the same as a message to the juniors. We have many of them listening to me. Ashish, can you comment something about it?
Yes, I think a lot of things will be clear when I speak about my version of the AC joint reconstruction. And there are many ways to skin a cat. But the 2 points that I would like to highlight, in addition to the 3 points that Sergio, you mentioned, the fourth point that you need for arthroscopic fixation is a fantastic knowledge of the local anatomy, the surgical anatomy. And the anatomy medial to the coracoid usually eludes us because we are trained not to go medial to the coracoid. Mm-hmm. And whether it's Latarjet or whether it's AC joint, it's very important to understand the brachial plexus, the musculocutaneous nerve. You must have enough testosterone to be able to go see and not harm it. And it doesn't matter, as you said, whether you do open Latarjet or arthroscopic. It doesn't matter whether you do open AC joint or arthroscopic. And I'm very firm on that. There's a big difference between open cuff repair and arthroscopic cuff repair. There's a massive difference between open Bankart and arthroscopic Bankart, but in these, not much. I think there are two major advantages on arthroscopy. That's why we went down the arthroscopy path. Is number one is you don't get the ossification that you see. In open AC joint, our first series of 40 patients, we had 3 patients with ossification along the CC ligament because there's a lot of periosteal erosion, dissection, hematoma. In arthroscopy, there's very little dissection and the flowing water will not allow the hematoma to form. Hematoma has all these totipotential cells. But the biggest advantage of arthroscopy is the anterior deltoid. In open surgery, strap incision, the tunnel on the clavicle is medial and your dissection of the AC joint is lateral. There are many surgeons who will take down the anterior deltoid. Anterior deltoid doesn't heal back very well and it leaves with a very sloughed out area. But if you are going to do it, then I suggest don't take down the anterior deltoid. Make 2 parallel incisions in the deltoid and weave the graft underneath. And that way you've kept the insertion there and you're just weaving the graft like a railroad underneath that anterior flap of deltoid. That way your bulk of anterior deltoid is there because forward flexion and pain is a big feature of anterior deltoid dehiscence, which is a little difficult complication to handle.
So just one comment that I really would like even you, so experienced guy, to think about. I would like you to pay attention in the incisions that I do when I do my very short presentation, because I had in so many years all of these problems that Ashish is mentioning with the anterior detachment of the anterior part of the deltoid. How did I fix it? I fully fixed it when I discussed it with much older guys and I changed my incision and I made it, I'm gonna show it to you, in the line of the clavicle, just as the transacromial approach described by Lippmann Castle 40 years ago. That was something that changed the game in my mind, in my patient.
I completely agree with you. Generally, we do not detach when performing an acromioclavicular separation, the deltoid from the acromion. We make the cut at the level of the aponeurosis, the fascia between the deltoid and the trapezoid, and the deltoid, and the trapezium. And I have never seen detachment of the dehiscence of the deltoid in acromioclavicular surgery. I have seen and I have had 1 or 2 cases of dehiscence of the deltoid when performing rotator cuff repair. For instance, I remember a diabetic patient, but I have not seen when you are working in this area, the deltoid has no problems.
And just one thing for the juniors to understand, because they didn't pick up the transition from open cuff repair to arthroscopic. I picked this transition very intensely. When you are doing an arthroscopic cuff repair, it does a lot of difference from open. This is clear in my mind, as Ashish have said. And one of the issues, it's written in many books, is because many above many other advantages is because you don't deal with the deltoid insertion. Because when you have massive tears and you have to see it very medially, I would say the damage, even not intentionally, on the deltoid, on the anterior part, on the medial part, it was considerable. And we ended this with arthroscopy. So it changed the game, of course. But I have a different incision in AC joint. I'm very happy to show this. And I stopped it having, my patients are not having problems with the deltoid insertion or deltoid weakness anymore. And this is what I guess Ashish was mentioning. Anyway, just before we start, Ashish's, Ildeo, any issues about how do you do the incisions to avoid deltoid problems? I think that this is so important because juniors, they have to understand all of the difficulties that we have in order to make their lives easier and in order to offer the best for their patients too. So any concerns you deal about the approaches? How did you suffer? I guess you suffered a little in the past, and what are you doing now?
Yes, in the beginning, I used to use Langer's line, skin Langer's line.
Yeah.
So I have studied a little bit about these lines of the skin. And Langer, when he did his paper, he used fresh cadavers to establish the direction of the Langer lines. So it was established for cadavers, not for the live,
like people.
Yes, human, yes. And that's a big difference because these plastic surgeons, they compared the relaxed skin lines. They were very much better using the relaxed lines. So I tried to use these relaxed shoulder skin lines, and I for the best result, I use my incision 90 degrees to the axis of the clavicle.
Okay.
And I try not to do more damage to the fascia than the trauma did. So I think we have to be very careful doing the dissection, and that's the message.
Okay. Okay. So Diego, do you have any comments? You can speak if you want.
No, yes, of course. I would like to say some things. It was a wonderful presentation, and it's a really good debate about hot topics in this pathology. I would like to know, because in the last few years, there is more attention focused on the horizontal stability also in the acromioclavicular dislocation. And we know that the vertical stability, it may be controlled by many techniques, but have you changed with your past experience, your approach, considering the horizontal stability in your technique?
I'm just gonna mention something, and I really want to know Ashish, because Ashish has very, I would say, clear points about it. I know from previous discussion with him, many guys, they are doing some loops or some sutures from the distal clavicle to the acromion in order to avoid anteroposterior dislocation. But the thing is that so far, when I finish the surgery, and I'm gonna show you my technique, it's so stable vertically and horizontally that I say, okay, that's enough to me. But I would say from a biomechanical point of view, it would be wise, or I would say strategical, to do something in the acromioclavicular joint, which would, listen to me, become more difficult if you do a Mumford, because you would have a gap, okay? But so far, I am not using this, but I know that Ashish has a very evolved thinking about it. So Ashish, what do you do and what are your concerns about anteroposterior instability, and what do you do surgically to address it?
I think Diego is right, because post-operatively, one of the failures, the patients who are very upset about surgery post-op results are the ones who are remnant anterior posterior instability. So apart from the fact that you are doing a cosmetic correction, the anterior posterior instability gets missed often. And sometimes you are overdoing it, sometimes you are underdoing it. And I think for all of us, when there's a grade 3 instability anterior posteriorly, all of us can diagnose it very easily. We just do an axial X-ray, which is a mandatory X-ray for all these patients preoperatively. It's often not done because we rely on a standard AP X-ray. But there are a few patients in the gray zone who are not displaced on X-ray, but post-operatively you find out after 6 months that everything is fine, repair is intact, but they are not happy because anterior AC joint pain. So it is the most important sign for this is under GA, before you do your incision, you look for instability in the anterior posterior plane. There should be a play of about 4 to 5 mm. If you see anything more than 5 to 6 mm, then use the same graph and go ahead and extend it through the AC joint. It's a small tip. The problem patients are the gray zone patients. Somebody who doesn't have even 1 mm of displacement, you do a AC joint reconstruction, Bob's your uncle. Somebody who has a gross displacement, you don't need rocket science to diagnose whether they need AC joint in addition to CC joint. Is that small gray zone, especially in females, especially in females.
Yeah, the only thing, no, just a second. There is something that I say to my residents all of the time. Medicine is not black and white. Medicine is 50 shades of gray. So when you have the patients in the middle, this is when you have difficulty. But one thing that I learned not only is to do, if I am understanding well, this test that Ashish is mentioning, I do intraoperatively too when everything is open. I put my finger, one finger below, one finger in the front, and I try to understand if there is, I would say, some mobility, some instability. My difficulty is how much should I value and how much should I say I don't care. I have a lot of difficulty about it to make an intra-op decision. Yeah.
Sergio, generally what I see when I end the cerclage is that there is no movement at all. Not vertically, not in an anterior posterior way, not at all. It is a very, very solid fixation. Even when you are, tightening the sutures, you see that the clavicle is going anterior, close to the coracoid. Some authors, as Dick Bohm and Golke, use the cerclage, but they also include a Kirchner wire just to, with the idea of getting a better anteroposterior stability. But I don't feel that that's necessary.
Okay. And Dr. Ildeu, he wants to say something. No, we are not listening to you.
I would like to ask you, Dr. Moya, about the biomechanical stability and the strength of the PDS over the time. So how long do you keep your patient using a sling, and how comfort are you to leave them to move freely the arm after this operation, because it's a resorbable suture?
Yes.
So.
Yes. Generally, the PDS is supposed to be reabsorbed in 180 days. And I am not scared about the immobilization of the patient, because generally I operate young people and I am not touching the glenohumeral joint. So I just had problems with the recovery of motion with one patient that I remember was a very special personality. But besides that case, I have never had problems with the recovery of motion. I have patients operated of both shoulders. So generally, I keep them in a sling from 4 to 6 weeks. Why? Especially because I want to give the chance to the coracoclavicular ligaments to heal. For me, that's very important.
So there is just one thing that I really want to mention, and this is another message to the juniors. There is a fashion, allow me to say a fashion, it's not a tendency only or a trend, a fashion, a big fashion of early mobilization. And what I say to my residents is early mobility is wonderful whenever it's possible. So I also keep my patients with my technique 4 weeks in a sling. I don't care about it, and I'm gonna tell you why. First, because I want the ligaments to heal without any mechanical strength bothering them. And second, I don't care about early results. I care about final good clinical results with no complications during the post-op evolution. So this is why I use a sling exactly like Daniel, and I don't worry about keeping them 4 weeks. And just another message. This is a situation in which having a post-operative frozen shoulder is very uncommon, differently from fractures and cuff repairs. We are talking about young patients, generally men, and from a physiopathological point of view, frozen shoulder is very unlikely in this case. So this gives me much more confidence to use a sling 4 weeks, just like Daniel. I would like Ashish now to talk and give us his presentation, and then we can continue. Okay, Ashish?
Sure. Thank you, Sergio, and all the rest of the faculty. It's a pleasure to speak to these elite faculty and all these others. I will try and finish before my 30 minutes, much before my 30 minutes, so that Sergio will give me 5 minutes extra with the case that I'm going to present, but
sure,
we'll deal with that later. So there are a number of controversies, as Daniel suggested, that this topic is full of controversies. Now, if I say that I have solved the AC joint problem, then I'll be lying through my teeth. Because when I trained in Liverpool, we were big fans of the Beaver-Dunn procedure, and it was almost a registrar procedure. And we saw a lot of these rugby players come back within few months with the AC joint going back up again. So my confidence level with Beaver-Dunn was very low. And I was always imagining what would I do when the first case came to me. And we hit upon this because we were doing a lot of knee surgery and ACL cases at the same time. But we must understand there's a difference between fresh and old. There's a difference between surgeons believe that if you treat fresh cases, you don't need to fix the ligament. It will heal. You just need to pull the AC together and bring the clavicle down, and the original CC ligament will heal. Now, the problem with that flaw is that none of the ligaments will heal on their own. In fact, Bankart is the only ligament we repair. And as Lafosse says, all other ligaments, there's a reconstruction. So it's a ACL, if it's a Brostrom procedure, these are all reconstructions, because ligaments, you must understand, fail with plastic deformation. They stretch and then they fail. And when they fail, they have already lengthened. So I'm not sure we should be treating a ligament differently, whether it's acute or chronic. So my treatment for both of these is pretty much the same. As we have already discussed, I still don't know 100% which is the patient that definitely needs AC joint with CC joint correction, but I'll give you some of the hints here. But I know several patients who have refused surgery or who have chosen not to do surgery and are still doing well. And my gut feeling is that somebody who's above 55, who's not into competitive sports, I tend not to operate them, and they still seem to do well. If they become symptomatic, they will come back, and then I would operate them later. But I can't explain why they are doing well and some young patients are also doing well, even without surgery. So there is a significant cohort of patients who will do well without surgery as such. So we have several options, and today you'll hear each of us talking differently with their different approaches, because each surgeon has his own philosophy on treating his AC joint. Whatever floats your boat, I will share with you my experience, but definitely I think there's enough consensus amongst all of us here that conservative treatment is a definite approach for type 1s and type 2. Surgery is a definite approach for type 4, type 5, and the type 3, which is the most common, is the controversial. And that is what we are here to debate also. Most of my talk will be debated on the type 3. You must know the anatomy. You don't need to do an MRI for AC joint unless you are expecting a collateral lesion. According to Marcus Scheibel, 20% of AC joint dislocation patients have associated lesions on the cuff and the superior labrum. But you must know that the conoid inserts 46 mm from the AC joint and the trapezoid inserts 26 mm from the AC joint. And that's why, because we advocate a single tunnel technique, our tunnel is always at 35 mm from the AC joint, and we would measure that. There are several problems with all the options, and the one thumb rule we know in medicine, if you have 60 different types of surgery for one condition, then I don't think we have one solution. It's the same with COVID-19, it's the same with AC joint dislocation. We don't have a consensus. We don't have a final answer. If there was one successful treatment, today we would be all using that treatment, like a bank card, like a rotator cuff repair. Yeah. The Bosworth, I think, is only to be mentioned in literature. It doesn't work in reality. Its complication rate is horrendously high. This is a patient who had a Bosworth screw 2 years before. His clavicle went up in spite of the Bosworth screw. The screw was a problem. And you can see that there's a track from the screw and there's a track from the repair. Fortunately, we use the same clavicle tunnel for our AC joint reconstruction with the semitendinosis. And here you can see a semitendinosis here, along with the Mercelin tape to reinforce, because this is a very difficult revision to do. The Weaver done to me has been proven, according to Gruter's study, that it has a 20 to 40% loss of reduction, because the strength of the CA ligament is almost 1/3 the strength of a CC ligament. You must understand the CC ligament, size for size, is the strongest ligament in the body. And those two, conoid and the trapezoid, collectively have a huge strength. So you need a very good quality graft. And that's why our first series of open surgeries were on gracilis. We migrated to the semity, and we swear by the semity, far superior graft than the gracilis as such. The synthetic CC reconstruction became popular. It became popular because number one, there were a lot of market forces. Number two, in addition to that, it was an appealing concept to do this arthroscopically. So it was a very easy surgery to sell to the patient that I will not do this open, I will do this arthroscopic for you. But then it has its own problems. One, it is non-biological. Number two, no synthetic ligament can take permanent cyclic loading. It's like your sharp femur nailing. If the femur doesn't heal, the nail will eventually break after successive cyclic loading. So you need a biological graft to substantiate your synthetic graft, and that together will work well. So that's important. Plus, the incidence of clavicle and coracoid fractures, erosion of clavicle, are quite common. There are several studies here I have mentioned which have shown a significant rate. There have been some studies with 50%, 80% failure rate. 6 out of 10 of their cases have had fractures. So do be careful, because it requires a good technique. Any technique on AC joint which requires you to drill through the coracoid will have a substantial failure rate of the coracoid or a fracture. So I'll come to that later. This is one of the patient. This was done here, and this was done by a colleague, and he's done the tight ropes. Day one X-ray, probably supine, looks good, and within 2 years, everything popped out. Surgeon went in, removed all the implant, but the patient is migrated up automatically. So synthetic ligaments are always suspect. You need a biological graft in there, which is durable and which is a long term. I would use the synthetic ligament for a fracture lateral and clavicle, or for a fracture with an AC joint dislocation when I'm using a plate. So that, I think, makes sense. The reason I don't want most of you all to drill through the clavicle or the drill through the coracoid, is the coracoid anatomy is very peculiar. Coracoid is not a straight bone. It's a three-dimensional bone which rotates in a very curvy linear fashion in the different prongs. So there's a rotational curve and a horizontal curve. And that's why it can create problems. When you're using a hook plate, so this was a study by Weinstein, where they did a double-blind randomized study between modified Weaverden and a hook plate. They found that they had coracoid fractures in 5.3% patients across the board. But if you look at the study by Marshall Schager from Germany in 2013, they had 20% failure rate of the coracoid or the clavicle combined together. So that's why if you have a technique that can skip a coracoid tunnel, you will save 2/3 of your complications just there. Any tunnel which is more than 7 mm will increase the risk of fracture. So this is what I meant, that a coracoid fracture is a serious problem. The coracoid turns, curves in a very peculiar manner. It's impossible to come in perpendicular unless you have done a few arthroletargies. And that's when you will understand what is the angle of the coracoid so that you go perpendicular to the coracoid. And certainly you need to watch the coracoid from the front end-on view, not through the glenohumeral joint, because you'll have no idea which way the coracoid is grown. There's a study on using half the conjoint tendon. I don't think it's worth its mention, so we'll skip that. But people have used half the conjoint tendon and flipped it over. The conjoint inserts at the tip of the coracoid. The CC ligament is the base of the coracoid. This is completely non-anatomical. And then Diego mentioned about horizontal AC joint stability. And I must say that I don't know for 100%. So whenever I'm in doubt, I will do a CC ligament reconstruction and use the excess semi-T to go across the acromion, drill a hole and pull it back and tie it over. It's sometimes safer to do that, typically in chronic patients, typically in patients who have pain. Now you must understand there are two sets of patients who have AC joint dislocation. Like the females, they come to you for a cosmetic correction. But there are a certain number of patients who have pain. Pure AC joint dislocation doesn't have pain. He has instability. If your patient has pain, go do a lateral X-ray. If you have a displacement anterior posterior plane, then you must for sure factor in an AC joint, AC ligament reconstruction into your CC ligament patient. So pre-op, I will always do a piano key sign and a front and back displacement to confirm that am I sure this is a uniplanar or a multiplanar instability. That helps me make my decision intra-op. This is an interesting study from Scheibel's unit. And this is peculiar because in this study, they tried to find what are the factors that can predict outcome. Their contention was that anything that's anatomically reduced or less than anatomically reduced may be symptomatic. If you have over-reduced, then there is less likely that they will have symptoms post-operatively because that posterior displacement does not occur 3 months post-op. Now, having said that, personally, I find it very difficult to reduce the AC joint back to its normal anatomy when they come in late. And that's why the study that Daniel mentioned, that you want to do it acutely because the chances of reducing are much better. So in the past, I would tell the patient to wait and buy his surgery and come back whenever he's symptomatic. But I've changed that now. And like Daniel, I would prefer to go in within 2 weeks, max 3 weeks, so that I can try and attempt and get a complete reduction. Otherwise, achieving complete reduction is very difficult. If any of you have this solution of achieving an over-reduced AC joint, please share it with me because I'm dying to know this. This is a paper from Imhoff's unit, and he mentioned about his success rate and joint separation. And he's had 17 type 5 injuries. I'm really surprised that he has had 17 type 5 injuries because we've seen only one type 5 injury as such. But he's had 8 failures out of 23 patients. But failure means a loss of reduction or pain and fracture. So failure doesn't mean that a redo or a serious complication. Any AC joint that went back, sprung back, they have considered that as failure. And they can manage overcorrection in 4 of these patients. And the ones that were anatomically reduced were doing well even at 2 years in their series. So this is our open technique where you expose the AC joint, you sometimes resect the AC joint. I used to do that in the past for chronic patients. And then you loop the semi-T around the coracoid. You must retain the pec minor and the CA ligament so that the graft doesn't slip anteriorly. There's a tendency to do that. And these two ligaments will help keep the tendon at the elbow level. And this is the animation to do that. So you railroad the graft. One end of the loop goes through the clavicle, the other is anterior to the clavicle. And I use a Setinsky forceps. This is a vascular forceps borrowed from your CVTS guys. And it's an excellent forceps to loop it around the coracoid without harming the musculocutaneous nerve. And then do a railroad technique, indirect suture shuttle relay, with one end, the thinner end of the graft that goes through the clavicle hole, 35 mm from the AC joint, and then you tie the graft over itself. I augment this nowadays always with a Mercilin tape, and then I suture the graft to itself. If I need to, then the excess graft is passed through the hole in the drill hole through the acromion and tied over itself. So this is a simple technique, and this is what achieves the complete reduction and a satisfactory. So it's a purely biological repair. There is no implant used, and I've extended this condition to chronic lateral and clavicle fracture dislocations. And this is a patient who came from Kenya with a 3-year-old problem, and we've managed to reduce it reasonably well. So currently we've moved to the arthroscopic technique to avoid deltoid morbidity, to have a faster recovery, anatomical repair, because we identify the footprint even in more accurate fashion. It is also appealing to the patient, but most importantly, as I said, we've not seen an ossification of the CC ligament in the arthroscopic technique, as opposed to 3 cases out of 14 are open technique. So here we first expose the coracoid, and that's a promontory on the tip of the coracoid. And once you expose the coracoid, this is the pec minor, which I've kept intact. This is the right shoulder. We are looking through the anterior through the Tajay portal. And on the lateral side here, you're seeing the CA ligament, and you remove all these subacromial burrs, the clavipectoral fascia, and then you identify the CA ligament, which is much more laterally, retain that, and then proceed back. You have to go a fair bit posterior to identify the clavicle and the stump of the CC ligaments here. So I'll fast forward that video a little, and that's your base of the clavicle, and you can see the remnant of the CC ligament so that you can identify your drill hole accurately anatomically. And then you use the Setinsky, which is coming from medial to lateral, and pass in a double loaded echelon so that you can railroad your graft underneath the coracoid without having to dissect much in there. And then this is the final repair, and you can see a comparison X-ray of bilateral X-rays and a good reduction. So if they come in early, you can achieve a good reduction and check this accurately. The clavicle cavar that's coming in, that's the bead pin before you drill the tunnel, usually 4.5 mm tunnel. You have to be very careful that it doesn't shoot through, and you have to go a fair bit posterior. It's far posterior than you would imagine. And when you align your tunnels, use your radio frequency. You would need a pump as such. Now, this is interesting. This lateral and clavicle fracture treated in the similar philosophy. I will come to that later. This is a 3-year MRI for a Ranji cricket player. This is a cricket player. It's a throwing sport in India. And we've done his MRIs 3 years later, and you can see that the graft is intact. As Daniel showed, it heals accurately, it heals in a robust manner, and it obliterates the piano key sign. That's also important. So this was our presentation at the ANA meeting way back in 2009. Later, we published this in the Journal of Musculoskeletal Sciences. And here we had a 15% loss of reduction. But even then, patients were not symptomatic. The loss of reduction was between 4 to 6 mm. We had one infection in an immunocompromised patient which resolved later. And we've had donor site numbness in 3 patients on the graft site where we took the semi-T on these patients. If you look at literature, even most of the literatures have had 19 to 23% of slippage and proximal migration of the clavicle. That happens across the board with a tight rope, with a graft rope, and even with the suture plate junction. Now the question about single versus double tunnel, I think we mitigate risks on the clavicle by doing a single tunnel. Indian clavicles are not that broad anyway. And this is a study from Banfi et al. They compared single and double tunnels, and biomechanically they were identical. So you can reduce your chances of clavicle fracture by keeping only one tunnel, but you need to position it between the conoid and the trapezoid. Hip and Styles paper identified complication rates. They're fairly high. So this is not a surgery like Bankart where there's 95% success rate. 15 to 20% complication rates are known. Higher complication rates were known with open suspensory fixations, open reductions, and arthroscopic procedures. But resurgeries were maximum whenever a screw fixation was used and an open reduction with circlage wires was used and open suspensory fixations were used. I think the biological technique with using SEMITI combined with a Mercelin tape is a very elegant technique. You don't use implant. It's an extra articular technique, so you can avoid deltoid insult and you do an anatomical reconstruction. So it's a fairly robust thing, but you must add the Mercelin tape. We've learned this. It helps reduce them much better. So in conclusion, I think there's a fair consensus across the world where we're moving towards a biological graft, which is permanent, which will strengthen and ligamentize itself to its strength. I don't prefer the allograft, I prefer the autograft, but I think in US they prefer the allograft much better for various reasons. And I have extended this technique to non-union lateral and clavicle fractures as well. Key take-home messages, avoid drilling the coracoid. SEMITI is a far better, stronger graft than the gracilis. Use a double loop to mimic the conoid trapezoid because they achieve different vectors because one is going through the clavicle, one is anterior to the clavicle. And fairly simple technique, whether you do it open or arthroscopy, though we've had loss of reduction in 15% cases and we completely accept that. Thank you very much.
So see, I really like it. Your what you have said. I took some very important points for us to discuss, and I'm going to start by this one. There is something that I learned this year with my good friend Ildeu. He taught me this, and this is very important for this presentation, which is when you have to understand the principle to choose the method. You have to understand the principle to choose the method. So you see, we are talking about principles. What Ashish has shown is so beautiful about the principles. What I do is a little bit different, but I'm just changing the method. The principles, they are absolutely the same. I would just like to highlight some points and we can discuss, of course. I'm going to show a case, but before that, Diego has a beautiful case to show. The juniors, they have to understand that what Ashish has said about the Bosworth screw having only an historical role is very, very true. Because besides everything that have been said, the clavicle even rotates around the acromion as we do a forward elevation. And this is why we have so many complications in terms of the screw breaking and getting loose. I have had in my life a constellation of complications with key wires and anchors. So this is why I stopped using them. And I'm quite sure that you guys, I would say Ashish, Daniel, must probably have already had difficulties with key wires and small infections, loosening, breakage. So we are coming to a common sense, as Ashish has beautifully mentioned. There is another thing that I really would like you guys, well, before that, in my opinion, suturing the ligaments is very, very difficult. So this is why I think that a reconstruction is so important. But just one comment, and then I would like you guys to speak. In my honest opinion, I am very confident about it. When you do a Weaver done, you are adding biology to the construction. But in terms of the strength of mechanical strength of the construction, the Weaver done fails too much. The coracoacromial ligament is not enough to hold such a force, because when we have an AC joint dislocation, this is good for juniors. We have a disconnection from the axial skeleton to the appendicular skeleton. What connects the axial skeleton on the upper limb, of course, to the appendicular skeleton is the CC ligaments. So to reconstruct it with a small coracoacromial ligament, I think it's too much. So, and this is why I add what I do, and I'm gonna show you to enhance the strength to the mechanical construction. And the thing is, what's very interesting, as I understood, is that Ashish use only the semi-T, but Ashish, do you use anything, I would say together with the semi-T? I didn't understand if you are using Merciless tapes. Can you give me your thoughts? I didn't understand very nicely.
So it's simple. When I use a semi-T, the semi-T will take some time to mature. It takes 8 to 10 weeks to integrate and ligamentize. And in that moment, there'll be a lot of cyclic loading. So to eliminate that, I add a Merciless tape, which is a 10 mm thick tape, along with the semi-T, which passes simultaneously. You would see that in some of our arthroscopy videos. So the Merciless tape gives immediate stability. More importantly, when you are tying and reducing the graft, it's difficult to cinch a semi-T and hold it. So the Merciless tape, you can absolutely scrumptiously pull in, reduce, and keep pulling till it goes a millimeter down, and then it snags beautifully. So then it holds it anatomically so that you get time and you don't damage the graft when you are reinforcing it. So speak. At time 0, Merciless tape gives you the primary stability for 6 to 8 weeks. Once the graft matures, ligamentizes, scars, then it takes over. So even if the Merciless tape breaks later, it doesn't matter, because the semi-T has taken over the biological job of transmitting the weight from the appendicular to the axial skeleton.
I fully agree. I'm very happy to see that all of the rationale that I use intraoperatively, you are using too. But my question is, do you use a semi-T in acute cases or only in chronic cases or revision cases?
So as I said, my treatment option is the same, whether it's acute or chronic, because I don't rely on the primary ligament. My impression is the primary native ligament has lengthened, plastic deformation, it is in tatters, and its quality is very poor. So I don't rely on that. So if that was the only time I rely on that is when there's a type 2A lateral and clavicle fracture. But I'll deal with that later when I do the cases.
So one thing, Daniel, what's your points? Because Daniel has said something so nice. What is acute and what is chronic? I have a difficulty to say in timeline, where do I do the cut? But having said that, I have, I would say, a mature, I would say, point of view, and I'm going to explain in my very small presentation, of when to use the semi-T. But Daniel, do you use the semi-T, yes or no? And if yes, when?
No, I use the Weaver-Dunn procedure. I don't not say that the semi-T is a bad procedure. It could be a good procedure. In fact, as a shoulder surgeon, we do not perform many chronic cases of acromioclavicular separations. That's another point. I do not use a reconstruction procedure in acute situations. So I have used the repair of the coracoclavicular ligaments. I have always found them in different shape, different level of damage, but I have always found them. In the last years, I have seen that the improvement of the MRI images have give us the chance to see the level of the damage even before you go to surgery. And now you can see what you see on the MRI when you approach the patient.
Ashish.
Yeah. Daniel, when there's a mid-substance failure, then perhaps it's reasonable to go in and repair the two ends of the tendon. Do you ever see an avulsion from the base of the clavicle that there is
Yes,
no other end
yes,
to repair?
yes.
What do you do then in acute cases?
There we used, generally there is a little stamp there. And you don't need to have a solid repair. Why? Because the PDS, the cerclage, is absorbing all the, the force of the area, the mechanical forces. So you just need to approach the coracoclavicular ligaments. It is not necessary to have a very solid repair. So we generally, what we do is we put stitches on the coracoclavicular ligaments, even taking, if we can, the periosteum of the coracoid, and then we close the cerclage. And when the cerclage is closed, the last thing that we do is to make the nodes of the coracoclavicular ligaments.
Okay, this is a lovely discussion. I am just controlling the time. So before Diego shows his very nice case, Ildeo, what's your technique to do this? Do you use implants, not implants? Because we really want to know your points about your technique.
Most important message here is the biological reconstruction. So it depends on the patient. If I have a very active patient that is a sportsman, and I like to do the transfer of the coracoclavicular ligament in the acute phase. So I like to use the tie rope instrument, and I do not over reduct using the tension of the tie rope, because the problems I had of penetrating the bone or failure, they were because of over reduction. So I like to do the reduction, anatomic reduction, to transfer the coracoclavicular ligament without.
Excuse me. Much probably you are transferring the coracoacromial ligament and not the
coracoacromial ligament.
Yeah,
coracoacromial ligament. Sorry, coracoacromial ligament, without cutting the clavicle, for the fresh cases, the acute cases. And then after doing this reconstruction, I like to do a cerclage with absorbable wire and over reduct. So in this case, the over reduction is not, the tension is not on the tie rope, it's on the cerclage. So that's what I like to do for the active sports patients. For the chronic ones, so if it's failure, I have the option to use semitendinous graft, which the papers comparing the strength, the coracoacromial ligament and semitendinous, show that semitendinous is better than coracoacromial ligament. So I keep in mind that if I need, I do the reconstruction using the semitendinous.
You see, what's nice for the audience to understand is how the philosophy is the same. The philosophy of Ashish, of Daniel, of Ildeo, and mine, they are coming to a common denominator, which is biological enhancement with something to hold the construction until the ligament heals. I'm very happy about it, but I just want to, as I'm having to control time, Diego, Dr. Daniel showed me that you have a very beautiful case to show. Can you present to us, Diego?
Yes, of course.
Can you share your screen?
Yes, I think.
Okay, good.
I think it's okay. Can you see it now?
Yeah.
Give me 1 second. I will share the full screen. Okay. So this is a complex case we treated a couple of years ago. This is a young lady from the south of our country, from Patagonia. She is really small, a very tiny person, like many patients you may have in Asia. She's 23 years old, and she already received 2 failed open surgeries, 1 distal or lateral clavicle resection, and 1 failed AC reconstruction. And she was referred to us 1.5 years after the 2nd failed surgery. So many years of bad function of that shoulder. And with this lady, the main concern, her main concern, was pain and weakness in the upper, in the shoulder, in fact. And of course, she had a spherical deformity that she wanted to correct. If we see the X-ray, we can observe there is, of course, the pull-out of the bottom in the coracoid process, that this may be the main cause of failure of the bottom. And if we measure the length of the clavicle, we can observe a loss of bone of almost 4 centimeters. So this is a critical situation in this patient because we have a short and unstable clavicle. If we take a look at the CT scan, we can observe that both tunnels are not done in the proper place, because the clavicular tunnel is pretty anterior and the coracoid tunnel is pretty lateral, that this is usually associated with failures. So without taking a lot of time, I would like to ask your opinion in this difficult, it is a chronic situation with a loss of bone of 4 centimeters in a young active patient. Which considerations do you have? Many of these topics have been discussed. Yes, Sergio.
No, what I just want to mention is this, and I'm very happy that I'm going to show a similar case from a radiographical point of view. When these chronic cases, I'm not talking about this complication, but I see chronic cases about 1 year. My record is 2 years old, type 5 dislocation. I'm going to show you with one year old. What happens is that you have a reabsorption of the distal clavicle. And in these cases, what I would do, besides taking the metal out, a trick that I do, and I'm going to show you in another case, you can I do 2 tunnels, but you can medialize just a little bit the tunnels in order to pull down the clavicle. I would do that with my technique with 4 T-bone sutures I'm going to show you, and I would definitely use a semi-T, and I would keep this patient, believe me, you can criticize me, 5 weeks in a sling. Maybe after 3 weeks, just some elbow motion, a little bit of external rotation, but no elevation, 5 weeks. Because see, you have just one more chance here to fix things. As I say to my residents, the human body is not a zipper that you can open and close all of the time. So the first shot is the best shot. It's already gone. The second shot is not as good as the first shot. Is already gone. So here I would do exactly what I do, and I would keep 4 T-bone sutures, medialization of the tunnels, semi-T, and a very serious period of immobilization. If a frozen shoulder comes, I manage it. I manage so many cases. That would be what I do. I think that I never use implants in these cases, and here that would be absolutely something not to be done. I don't know, Ashish, something different in this case, in this difficult case?
Yes, I think the problem is the goose is cooked because there's a drill hole in the coracoid, and this case is Diego is clearly reinforcing exactly the point that be very careful with drilling coracoids. I would definitely use a graft. I would go medial to the clavicle. 35 mm is my landmark, and do biological. I might swing the other end of the graft posterior rather than anterior, because since this drill hole is anterior, there's going to be a lot of stress riser there anteriorly on the clavicle.
Okay, Dr. Ildeu, do you want to say something?
I had problems similar problems operating these tiny ladies, because the coracoid is thin, so it's not easy to get a proper position of the tunnel to put the implants. So in these tiny ladies, I prefer to do a cerclage, because the chance of breaking the coracoid exists as well during the procedure.
Okay, well, Diego, can you go on?
Yes, of course. I want to mention one concern we had when we planned the surgery, that because we have 4 centimeters of bone loss, the tunnel position, if we want to do a tunnel in the clavicle, had to be really more medial, because we cannot reconstruct in an anatomical fashion. And also, this patient being in this situation for so long, the osteopenic situation of the clavicle that has no function for almost 3 years, it's a concern for us too. So just to go on, we had a wide tunnel that is positioned, in fact, not that lateral, it's more at the level of the coracoid process. And we decided to add 2 more tunnels of 4 millimeters. And we decide this measuring the length in the anterior posterior orientation of the clavicle. There is a nice paper from Peter Millett considering when it's risky to do a hole between the length of the clavicle and the size of the hole. And you need to be afraid if you compromise more than 20% of the relationship between these two. We avoid doing a tunnel in the coracoid because it has already failed once. And we use, as Hashish showed, Satinsky or a suture passer to pass underneath the coracoid process. Then we do a side-to-side suture to stabilize the horizontal mobility of the AC joint. And then we put 2 tenodesis screws as shown by Masoka. Finally, we cross over the remaining tendon to stabilize the whole construct. So if you see the surgical pictures, you can observe the original tunnel done in the clavicle that is pretty wide, and the lack of bone we have in the middle. So you need to go pretty medial to stabilize this clavicle. So we use a temporary fixation with a cerclage as well. And here you can see the acromion with the palmaris longus autograph we use in these patients. And in this patient, we added an autograph of semi-T because it was really small also, the palmaris longus, and we wanted to have an additional fixation point. We stabilized it with 2 pretty small screws. It's not very different of what you use in a clavicle fracture, a 4 millimeter tunnel. And after we finish the fixation, we cross over all the tendon to the acromion. Finally, in this situation, and this is not our preferred method, it's the only situation where we consider a hook plate, is because this whole stabilization was pretty medial, and it's not in the correct vector of resistance of the ligaments. So we put in this unique situation a hook plate, and we had this X-ray with a good reduction, and we have a 5 months post-op situation like this. And the lady was going pretty good, but she had a limitation in mobility. The anterior elevation was limited to around 100 degrees. So my question to the panelists, do you consider removing the plate? How do you handle this situation? And is this a situation for you to use a hook plate, or not even in this situation?
Well, I'm just gonna give you my thoughts. In my opinion, I know it's easy to say the patient is not in front of me, but in my opinion, I understand all of the concerns, but I would still not do it. I would worry. Well, I really trust in the method that I use, which I'm gonna show is very similar to what you guys do, and even in very difficult cases. But I would not use a hook plate, even because there are issues with removal, and I'm always worried about the damage that the plate does to the cuff. I am a cuff. I've been saying for so many years, I am a cuff savior. I'm not a cuff damager. So this is why, this is one of the reasons why I think that the hook plate should, I never use it. And to be very honest, I would not use in this case. Ashish, what about your points, hook plate? I guess you would not use it, but please tell me your thoughts. Tell us your thoughts.
Yes. Diego, I think you did a fantastic job with the two graphs, and with an allograft and palmaris longus. You've got an autograft, biological, and an allograft. So I would have left it at that. The problem with the hook plate is it always needs to be removed because of damage to the acromion. I'm not so worried about the rotator cuff because the hook tends to go far posterior, but it can create an acromion fracture or a stress riser. And addition of the hook plate, I can imagine that you wanted to be very safe, and because it's the third time, it's a difficult call. But now you have 5 holes in the clavicle. The original one, the fresh one that you made for your graft, and 3 from the screws of the hook plate. When that hook plate comes out, there are going to be a clavicle which has 5 holes inside it. It's almost pepper potted. So you should be very careful.
Yes, I agree with you. Daniel, do you want to say something? Your mic is off, Daniel.
Daniel?
Sorry. No, I agree that in these cases, the use of the plate is a good indication. Mm-hmm. You know, we are doing a salvage of 2 surgeries. Perhaps we would have never arrived to this point just using 6 PDS sutures in the first surgery. So that's why we insist on making it simple if you have a good evidence of this. So I think that young people must think about that. If you operate on my shoulder, I prefer a simple and robust repair, acute repair, and not go in what we see even with shoulder arthroplasties nowadays, patients going from one surgery to the next one and the next one and the next one. And you know, when another person is offering her or his shoulder for surgery, it's easy to make very heroic decisions on type of surgery. But I think that besides the mode and besides many other biases, we must consider that we must give people the best result, the most simple option and most accurate option. But this is a great case.
You know, Daniel, this is such an important message for the juniors. You must always think not about the first surgery that you are doing, but about the complications that you may have in future. And this is why I have been doing in all of my situations simplicity enhancing biology. But about this case, Ildeu was raising his finger. He wants to say something too.
Well, revision cases are always complicated. So they are complicated for everybody. And I think that when you are in this situation, third operation, you have a lot of options, but you have reconstructed the AC joint ligaments, the corticoclavicular ligaments, and you really need stability for them to heal. So you did the job. So I think this is a discussion should be done with the patient, and if the patient is okay for that, so it's a good option. But there are complications related to these methods that they have to be aware. It's just it.
Okay, Diego, but can you tell us what happened in the end? Because we are all very curious.
Oh, yes, of course. I want to say only that we discussed it with the patient and it was planned as a 2-stage surgery. And if you consider my concern, and I don't regret using it, even though we know the risk of fracture we may have after the removal. If you see, the only fixation point we would have if we don't use the hook plate is medial, and only one point that is there. So I didn't trust so much the bone being dysfunctionalized for 3 years in this lady. But so we decided to remove, and the X-ray it could be scaring. If you see, you have, as you say, 5 holes, and with a really small and tiny clavicle. But this lady, well, the problem we have, she lives far away. It's more than 1,000 kilometers from our hospital. So we don't see her a lot. But we had the luck to do an MRI of this patient. And we can see, if you pay attention, the neo ligaments passing.
Diego, just tell us how many months after surgery is this MRI? How long
this
after
MRI
surgery?
The MRI is around 8 months, because it was 3 months after the takeout of the plate removal.
Okay. Yes.
And the same as the X-ray, I think, is about 6 months after the removal. And what it was incredible is, well, if you see in the acromion, there is a small hole, as you say, but this hook plate goes really posterior, so I was not concerned about the calf. But of course, yes, about the acromion. And she had a really good result in terms of healing of the ligament, and in terms of mobility as well. She recovered all the mobility really soon after the removal of the plate. So she has a good mobility, she has a strength, she goes to the gym 3 times a week, and she's really happy. It's a really difficult case, and I don't like hook plates, but in this case, it was a risky maybe choice, but it did well.
You see, it's a lovely result. I just beg to this lady not to fall again, because she cannot fall again to the rest of her life. Yeah, yes. She cannot have anything more with this clavicle. You see,
very religious clavicle. You see, it's a holy clavicle.
It's beautiful. You see, as a matter of time, I would like to show 5 minutes what I do, because I think it's very interesting. Just a second, and then we can keep on discussing. If you allow me to share my screen, I'm gonna be fast. So I'm gonna start here. So the thing is, I'm gonna be very, very objective. So the thing is, how have I, Sergio, after so many years, how have I found peace after so many difficulties and losses of reductions and broken key wires and loosened anchors? I use subcoracoid sutures. I use 4 number 5 Etibond sutures, 2 holes in distal clavicle, I'm gonna show you, and I transfer the coracoacromial ligament to enhance biology. So this is what I do. I use 4 number 5 Etibond sutures, and I tie them separatedly. As Ashish said, it's never wise to tie them together. I tie 1, and then I tie 2, and I slowly go doing a reduction, and I transfer the coracoacromial ligament, and I'm very happy with that. This is another way of seeing this. So the surgeon must be extremely organized. I have 4 sutures. You must have a lot of organization. This is again the 4 sutures. Let's see it very closely. So, and I tie them very slowly, each one by each. Here we are seeing a very beautiful photo of what I do intraoperatively. I keep the suture stents not to make a mess with them. This is a super beautiful photo of this. We are seeing here the coracoacromial ligament already detached from its acromial insertion. And here we can see exactly the idea on the right side and doing exactly the same thing on the left side. Then I tie them each by one each by each. And as we see here in this big photo, I see here the coracoacromial ligament transferred to distal clavicle, and I am using only a #1 vicryl screws. I never use any implant. So this is a very beautiful photo that I have done in another case, in which we can see here the coracoacromial ligament, okay, detached from the acromial insertion and transferred to the distal clavicle. And you see I am only using #1 or #0 vicryl screws. Radiographically, so this is the pre-op in a type 5, and this is 6 weeks post-op. I want you guys to pay attention in details that took me years and years to understand. This is my 2 holes, and I tried for many years, 2.0 key wires, 2.5, 3.0, 3.5 Steinman pins. The magic number, in order to be safe and not to stress the fracture, the clavicle, to create a fracture, is 3.5. Believe me, it took me 3 years to get to this ideal number. These are my tunnels here, and you can see a perfect reduction after 6 weeks. I'm not going to show you the final results because I want to concentrate in 2 very difficult cases. So what do I do in chronic cases? So when I'm talking about chronic cases, I'm talking about cases 1 year, 1.5 years. In this case, you can see a very big reabsorption of the distal clavicle. This is 1-year-old lesion. Here we can see a very important reabsorption of the distal clavicle, just like happened in Diego's case. And you can see that the density of the bone is less, is a little more blacky. And this is something that make you have a lot of care when drilling your tunnels. So this is exactly what I have done, but I'm going to show you how I do. This is a very nice photo in which we can see, pay attention, I never pass the semi-T through the clavicle because I think that I am very afraid of doing a big hole and having a fracture. So I pass it in a technique which is called the loop around. One part below, as we are seeing here in this very beautiful photo, one part, firstly, a reabsorption of the distal clavicle here. And then one part of the semi-T is passing below and the clavicle, subcoracoid and posteriorly. And this other part here will pass anteriorly after I tie the 4 sutures. So this is something that I think is very important. This is what I call the shoelace knot, as I tie my shoes every day. So in this very big photo, I am tying it, and I'm gonna fix it, believe me, with number 3 or 4 nylon sutures, and it becomes very strong. And this is the final construction. This is another case because it's difficult to have beautiful cases, beautiful photos in the same case. So what we see here, this is, just a second, this is 1 week post-op. This is something that Ashish has mentioned. Hyper reduction is very important to get hyper reduction because you will lose this over time. I never had a perfect reduction in a chronic case. So here we are seeing 3 weeks post-op, still hyper reduction. This is now 6 weeks post-op, still a very good reduction. But when I come to 6 months, so I measure that bilaterally in the computer, so I lost 3 millimeters. And this is something that happens all of the time. But in spite of that, the clinical results, they are always very good. I just want to, here we see 3 millimeters. I just want to mention that according to Federal Council of Medicine in Brazil, I can show the face of the patient in scientific presentations. I just want to highlight that. So this is my incision. Is absolutely just a second. Is big, I know. Seeing is achieving. I cannot fix what I cannot see, but is in the line of the clavicle. And with this, I open and I close the deltoid, and I have no more problems with the deltoid anymore. Just a second. So this is here. The patient, I'm just gonna show you the final clinical result. A very good, this is 6 months post-op. I know it's a big incision, but this is how I do it. So a full elevation, absolutely full elevation, no scapulothoracic compensation. She's doing very fine. She's not a very smile, she doesn't smile too much. Absolutely good external rotation. And she's doing everything at home. She's a housewife. This is the non-operated side, and this is now the operated side. No scapulothoracic compensation, absolutely good result. I'm asking her in Portuguese, are you doing everything? She's saying tudo. Tudo in Portuguese means everything. This is my last case. So what about very difficult clavicle fractures? Many young orthopods would freak out when they say this, and many guys will do here a hook plate. I know, I never use it. The message is, don't care about any of the fragments, just manage it as an AC joint dislocation. This is a beautiful photo in which we can see the fracture on the left side. I don't care about it. This is another way of seeing this. We can see the fracture on the left side. The fragments get absolutely reduced as you pull the clavicle down. And this is the immediate view in the final, in the end of the surgery. Hyper reduction. It's very important to have hyper reduction because you have a tendency to lose it over time. This is 1 week post-op, hyper reduction. This is now 6 weeks post-op, still hyper reduction. And this is now 11 weeks post-op. We can already see callus. What I want to say is this, I always say this all of the time. Bone healing is a phenomenon, as Rockwood says. It takes months and years. So I always try to keep these boys very close to me to document radiographically the healing in spite of the fact that they are wonderfully from a clinical point of view. This is the moment, in these cases, 12 weeks, when they say to me, Doc, I don't know why you are always asking me to come back, because I am very good from a clinical point of view. This is the moment, believe me, when they disappear, because they are, I always ask them, come in 2 months, come in 2 months, but it's difficult as they are clinically asymptomatic. So this is the last video. This is the patient, very young boy. This is the same incision, is big, I know, but I split the deltoid in the line of the clavicle. That doesn't hurt the deltoid anymore. He's saying, I have absolutely no pain, absolutely good forward elevation. He's saying, no, I have absolutely no pain. Now we are seeing external rotation. See, even with a prolonged period of immobilization, we don't lose. He's saying, I am absolutely okay. Okay. And so this is the technique that I use. Yeah. This is just what I wanted to show to you guys. And you see, it's very similar to what we have been doing, but it's a different way of achieving the same points. And the matter is, Sergio, when do you use the SEMI-T? I never use the SEMI-T in acute cases. I use in chronic cases, but it's difficult to say what is chronic. Daniel knows with 1 year, 1 year is very easy. It's absolutely chronic. In 6 months, it's chronic. What about 1 month? It's chronic. I don't know. So maybe I am absolutely, I would say, incorrect. The number in my mind, from a biological point of view, is 3 months. But you see, that is a gray zone in which is difficult. But the principles are the same. And and with this technique, I have been very, very happy. So, Daniel, about my technique, you can make all of the critics that you want.
No, I just want to say that many years ago, the limit was considered 3 weeks. And
Okay.
with time, it was limited to 2 weeks.
Okay.
Having a patient with 1 month follow-up, I would go to surgery prepared to do a repair or a reconstruction and do according to what I see. So I think that the last word will be, and the last decision will be done during surgery.
But and what about making a distal clavicle resection? I would say in this case, I even didn't need it because nature had already done it with the osteolysis. Okay, mm-hmm. But you see, 1 week, 2 weeks, it's senseless to do a Mumford, a distal clavicle resection. 6 months is, I would say, quite reasonable. But if the patient is 2 months, 1.5, how do you do? What I do, and I want to hear you guys, is I see with my eyes the status of the cartilage. If the cartilage is okay, I'm going to preserve it. If it's looking very ugly, I'm going to do a Mumford to avoid a painful AC joint in future. Do you feel the same? And I really want to hear you guys, Ashish, when in these midline cases, in the gray zone, when and why you do a distal clavicle resection. Daniel, you can start.
I think that fortunately there are not too many cases coming at that stage. So
okay.
We just try to, if we feel that the patient deserves a repair, we try to force that decision or to give the patient all the information saying you need to do this surgery as soon as possible. But for me, if the patient is coming 2 months later, generally I do not rush. Except if the patient has blocks of the movement, or sometimes they are coming complaining of that. But if the patient is coming after 2 or 3 months after an acromioclavicular dislocation, I do not rush. I try rehab and see how it works. And if it doesn't work,
type 5, but even in type 5.
Well, some authors says that even type 5 should be divided in type 5A and type 5B.
Okay.
I have seen, for instance, rugby player of our national team with a type 5 dislocation playing with no problem and never got surgery.
Okay. Before Ildeo speaks, I don't know if Neeraj and Ashok are there, but Neeraj and Ashok, if there are questions from the audience, you can share with us because I'm trying to see below, but I am not seeing. In spite of that, Dr. Ildeo, how do you manage to do a Mumford or not in the gray zone? I think this is a very important question for the juniors and the general audience.
Are in the gray zone, always wait a bit more. I think there is no rush for the procedure because the results will not change. So Mazoka said that for us that the patients that were operated on the acute phase, comparing to the ones that were operated in the chronic phase, they might have similar results, which keeps me in a comfortable situation. So I would like to wait a little bit more because I try to rehabilitate these patients, to stabilize the scapula, to try to give function. And most of these guys, they do not have pain. So I don't have to reoperate the majority of them. So for the ones that we have a painful shoulder, so I indicate the reconstruction.
Just one thing, and I really want to know, Ashish, many friends of mine, they say when some patients, they come with type 5 after 2, 3, 4 months or more, and for reasons that Sergio, I cannot explain, they are absolutely painless. in spite of the cosmetic deformity. I have difficulty because from a pathophysiological point of view, this is good for the juniors. According to Rockwood, the deltoid trapezial fascia, it's torn in a type 5. And even though in many cases, in spite of the cosmetic deformity, they are absolutely painless. Why that? I cannot explain. Ashish, your thoughts about why are they painless? And if they come painless, do you, as a rule, leave it alone in spite of the cosmetical deformity?
Sergio, if the AC joint patient is painful after 3 weeks, I'm worried because we are dealing with instability. And
okay.
as shoulder dislocation, pure AC joint dislocation are painless. They have instability. That's their problem. When that ACL starts getting a meniscal tear, the pain appears. When the Bankart starts getting frozen shoulder or a partial rotator cuff tear, that's when it gets painful. That's why they don't come in early. So most of the AC joint dislocation patients, when they come with pain, the pain is on the medial scapular side, and Bain Kabler describes that as because of the dissociation between the scapula and the clavicle. So that's their worrying symptom. So when they come after 3 months, 4 months, is the scapular dyskinesia that brings them in. And moment you reduce the anatomy, that pain will go away. So
yeah.
LDU is right. In my initial open AC joint reconstruction, I used to do lateral and clavicle excision for most of the late people who came after 3 months. Since I switched into the AC joint, because we started doing arthroscopy, to reduce the learning curve, we stopped doing the lateral and clavicle because it was a difficult surgery initially. And none of them came back with pain. So we thought that we are overdoing it. So we stopped doing lateral and clavicle excisions since we started doing arthroscopy. And over the last 5 years, I have not done them. And I say with conviction that I do not regret. So none of them have come back with pain.
So you see, before Diego speaks, now I have a very tricky question, and I want you to answer, and any other can give their thoughts. See, if you pick up a guy 5 months after the trauma, you do it open, and you see a very damaged cartilage from a macroscopical point of view in the distal clavicle, that would lead me to a reasonable decision of making a distal clavicle resection to avoid problems in the future. And if you, Ashish, would be doing the same case arthroscopically, you would not address the AC joint dislocation. So maybe the message, this is something that I'm thinking about now, this can be a lesson to me and to all of the others, that maybe we would be over-indicating a distal clavicle resection in these cases. What do you think about that, Ashish? And what do you think about that, Diego? Diego wants to talk, but I want to hear Ashish. This is something very interesting because that would be a new idea. What do you think, Ashish?
No, it's right. I completely subscribe to this. And especially for the juniors, the whole message today, Daniel, Sergio, myself, keep it simple. So don't add stuff to this complicated. As it is, we don't have a consensus. So there is no need to do that. Unless there's an objective reason of local tenderness, extremely rare. I have not seen it in the last 5 years. And
okay,
I think I agree with you, Almada, that he's not seen a revision. We've not seen a revision because of pain in the AC joint.
Okay, and Diego wants to speak.
Yes, I want to say that I agree with Hashish's experience. I think most of the time it's not a problem. We may see in the X-ray arthropathy in the AC, but it's not painful usually. But I want to consider also that there is a gray area also in between leaving the AC joint and doing a Mumford. If you see a thick cartilage, you can only resect the cartilage without resecting 1 centimeter or 1 centimeter and a half of distal clavicle, because it has been shown that after you remove 5 millimeters of bone, you lose some stability. So when I have the doubt, I only resect the cartilage if I do a chronic open surgery.
That's a very important point, Sergio. In open surgery, if you're going to do a resection, then you're going to sacrifice the AC ligament. amongst the AC ligament, there is an anterior part, superior part, and posterior part. The superior is the thickest, strongest, and most robust. So be very careful.
So, and you see, if we talk about a distal clavicle resection arthroscopically, it doesn't matter why you are doing that. You must always preserve the superior ligament. This is a message for the juniors. But in the other hand, see, if I do what they call a mini Manford arthroscopically, I would be afraid of, as Daniel has shown, post-operative painful synostosis, because nature would try to do something over there. As I have said in the beginning of the presentation, whenever I'm doing an open Manford, it doesn't matter the reason why, I pick up electrocautery and I burn it in high temperature in order to kill the biology over there, to avoid bony activity over there and a post-operative painful synostosis. In the same way, arthroscopically, in the end of the Manford, I put the radio frequency device very high temperature, and I try, I would say, to not to cut, but to kill as long as I can biology over there. In my perception, over these 15 years, very easy to come in open fashion with electrocautery very high, and it becomes very, I would say, blacky, yeah? And you are happy with that. Arthroscopically, it's very difficult. Even if I put the radio frequency device very high, I don't know if I am killing the osteocytes to avoid post-operative synostosis. This is why my tendency is to, in one hand, I preserve the superior AC ligament, but in the other hand, I am afraid of doing 5 millimeters. I prefer, I would say 8, 9. And how do I measure that? This is a tip for juniors with the size of the shaver. If the shaver is 4, then I have to double it. Yeah, but see, I am very afraid of post-operative synostosis. Daniel, you showed a case of post-operative synostosis. Do you have any other one? Because, see, this is a complication, and this is important for juniors.
Yes, there were, when we analyzed these cases, there were different complications. There were infections. There were one infection, I remember. The study included around 40 patients. I think there were 44 patients, and there were diagnostic errors, technical failures, and complications. We consider complication a poor result in which no one is responsible. There is no, no diagnostic error. There is no technical failure. It's something related to the nature of the pathology. And so we include their infections, we included this kind of synostosis or ossifications. And there was something that was described by Rockwood for the first time, that were the hypertrophic scars. There were patients that Rockwood needed, there were 3 cases, needed to go back to surgery and resect the scar that was really extremely painful. Another trick that we used to apply was surgical walks to, try to stop bleeding. That in fact bleeding
is yeah, just like some guys do when taking graft from the iliac crest.
Mm-hmm. Yeah, that was very popular as well, and you can use it. Is not a big deal. Friends, I will need to leave because I have a surgery. So I'm sorry, but it was a pleasure. And we, as you said, could keep on speaking for hours, but I'm sorry, I will need to leave.
So Daniel, so you see, as I know you have a surgery, Ashish is in the office. I am worried about time. We are 2 hours and 15 minutes. So I'm gonna finish it now, okay? Because the limit is 2.5 hours. But the thing is, so I just let me give a message, and you can all say bye-bye. So
Okay.
see, my good friends, I'm very happy that we have so many Star Wars here. We have always to be together in order to, I would say, to enhance spreading knowledge all around the world. So I just want to say thank you, not to you guys, but to Ortho TV, which has been very, very kind to us. A big thank to Dr. Ildeu, who has been very, very kind to us. And I just, I really thank you from the bottom of my heart. This presentation will be in YouTube, in Ortho TV, and they always allow me to pick it up to put in my YouTube channel as the previous ones. I am very thankful to Dr. Ildeu, who is always with me in this big journey. And I don't know if Dr. Ashok, which is the king of Ortho TV, to go together with Dr. Neeraj, if he wants to say something before we finish. Hello, Ashok. You are muted.
No, you can hear me. Apologies for joining in late, but I could catch up the last 1.5 hours of the webinar, and it was really excellent. The presentation, the cases, the moderation were all international class. So thank you very much for doing this with us. Okay. And Neeraj, any message?
So thank you, and let's fix up a webinar for October as soon as possible.
Okay, we will do it. Thank you very much. And you know, from the bottom of my heart, and Diego, you are now my new friend, and we keep on talking, huh?
Thank you so much, Sergio. It was a pleasure for me.
Okay. Thanks, everybody. Bye-bye.
Bye-bye. Thank you.
Okay.
Take care. Enjoy. This was excellent.
Thanks, Ashish. Thanks, Ashish.
Bye, Ashish. Bye.
Bye, you. Bye, Daniel, Diego. See you. Thank you, Neeraj.
Bye-bye.